There is a moment that happens in almost every doctor's office right before someone signs a consent form, and almost nobody talks about it. It is the moment where the pen is already in your hand, the nurse is already smiling, and some quiet part of you wants to ask one more question but doesn't because it feels rude, or late, or like it might annoy the very person about to operate on you. I have watched that moment happen hundreds of times, and I can tell you exactly which 5 surgeries are most likely to be the ones where that unasked question would have mattered most. I'm not going to tell you to avoid surgery. I'm not going to tell you surgeons are the enemy. What I'm going to tell you by the end of this video are the 5 operations where the risk to an older body is dramatically higher than most people are told going in, and exactly what to ask before you ever get near that consent form. Stick around, because number 3 is the one that surprises even people who work in medicine. Before we get into the list, I want to ask a favor, and it will take you less time than it took to read this sentence. If someone in your life is over 60 or getting there, and you want a simple way to walk into any surgical conversation prepared instead of scared, I put together a short, free guide that covers exactly what we're about to talk about, plus the questions doctors wish more patients asked. It's linked right on this screen. You don't need to pause the video or write anything down. It'll be there when you're ready. And if this video ends up helping you or someone you love, hitting subscribe and dropping a like genuinely helps this reach the people who need to see it before their own surgery date, not after. Let's start with something almost everyone intuitively understands, but medicine has been slow to catch up to. If you took an engine that had run for 20 years and one that had run for 70, and you pushed both to their absolute limit, you would not expect the same outcome. You'd expect the older engine to strain in places the newer one wouldn't even notice. That's not pessimism, that's just wear. And for a long time, medicine treated a 70-year-old body roughly the same way it treated a 40-year-old one. Same surgical playbook, same recovery timeline, same expectations. That's finally starting to change, but it is changing slower than the number of people affected by it. Here's what's actually happening under the hood during a major operation on an older body. The heart is working overtime to keep pressure stable. The lungs take longer to fully clear anesthesia out of the system. The kidneys, already running a little slower with age, have to process every drug used during the procedure. And then there's the one that catches families completely off guard afterward, the brain. Older brains can come out of anesthesia disoriented in a way that doesn't just fade by dinner time, it can linger for weeks, sometimes months. There's a real medical term for it, and once you hear it, you start noticing how often it's mentioned quietly in hospital hallways and almost never mentioned before the surgery happens. Now, before you assume this means age is the enemy, let me stop you right there because that's not what this is about. I have seen people in their 80s bounce back from major surgery faster than people in their 50s. Age by itself tells you almost nothing. What actually matters is something doctors call physical reserve. Basically, how much cushion your body has left to absorb a shock. Two people can be the exact same age and have completely different amounts of that cushion. That distinction is the entire reason this list exists, because the danger isn't really about a number on a birth certificate. It's about whether a body has enough reserve left to survive not just the operation, but the weeks of recovery that follow it. Keep that idea in your back pocket because it's going to come up again and again as we go through these 5. The first one on the list is open heart surgery in a body that's already running on a thin margin. Coronary bypass surgery is one of the most common major operations performed on people over 60, and for good reason. When arteries are seriously blocked, rerouting blood flow around the blockage can be life-saving. But here's the part that rarely gets said out loud in the consultation room. To perform that surgery, your heart has to actually be stopped. A machine takes over the job your heart and lungs normally do while the surgeon works. In a healthy 60-year-old, that's a manageable, well-tolerated process. In a frail person in their late 70s who also has some kidney trouble and a little cognitive slowing, that same bypass machine puts a strain on every organ system at once, all simultaneously trying to compensate. In patients who are already frail, this kind of surgery carries a meaningfully higher chance of serious complications, things like stroke, kidney injury, and extended time on a breathing machine. And in the highest risk group, a real percentage of patients don't make it through the first month after the operation. That's not meant to scare you away from ever having heart surgery. It's meant to make you ask the one question that changes everything, which is whether a less invasive option exists. In many hospitals today, there's now a catheter-based alternative that repairs the valve or vessel without ever stopping the heart or opening the chest. It's less dramatic, but it's often dramatically kinder to an older body. Ask if you qualify. That single question might change your entire outcome. The second one is aggressive spinal surgery for chronic back pain. If you're over 60, I would be shocked if your back hasn't come up in conversation at least once this year. It's almost universal at this stage of life, and increasingly the answer offered isn't physical therapy or an injection. It's a multi-level fusion with hardware placed up and down the spine. Now, to be completely fair, there are situations where spinal surgery is absolutely necessary. No gray area at all, things like active nerve compression causing loss of bladder control or sudden weakness in the legs need immediate surgical attention. But elective fusion for ordinary degenerative back pain in an older patient is a different story, and the research on it is genuinely uncomfortable. Complication rates for complex spinal fusion in patients over 65 run dramatically higher than most people expect. Things like blood clots, infections, hardware that shifts or fails, and a strange phenomenon where the vertebrae right above and below the fused section start to break down early, because the spine's natural mechanics have been permanently altered around a section that no longer moves. And here's the part that stops most people cold once they hear it. Several major studies have found that for a lot of degenerative spine conditions in older patients, aggressive surgery produces no better long-term pain relief than physical therapy and targeted injections. Not slightly better, comparable, but with dramatically more risk attached to it. I once heard a respected spine surgeon say that sometimes the best operation is the one you talk yourself out of, and I have never forgotten that line. If you've been told surgery is your only option for chronic back pain, that's exactly the moment to pause and ask what a non-surgical path would realistically look like. The third one, the one I mentioned earlier that tends to surprise people, is aggressive cancer surgery in a body that's already fragile. I understand the instinct here completely. Hearing the word cancer makes almost everyone want the same thing immediately. Cut it out, get it gone, deal with it now. That instinct is human, and it's not wrong. But here's something that decades in this field teaches you that no textbook really prepares you for. The actual goal of cancer treatment isn't simply removing the tumor, it's giving the patient more good years of life. And every once in a while, in a frail elderly patient, an aggressive surgical removal accomplishes the first goal while quietly working against the second one. Take one of the more extreme examples, a major pancreatic surgery that can take the better part of a day to perform and involves removing and reconstructing several connected organs. In a healthy 55-year-old, it can be genuinely life-saving. In an 82-year-old with heart disease and reduced kidney function, that same surgery might technically succeed, the tumor is gone, and yet the patient can pass away within weeks. Not from the cancer, but from the surgery itself trying to heal in a body that didn't have enough reserve left to do it. There's a term for this, failure to rescue, meaning a complication occurs that a stronger body could have weathered, but a weakened one simply cannot. Research from major surgical associations has found this happens in a meaningful share of elderly cancer patients who undergo major resections. So, if you or someone you love is facing this decision, there's one question worth asking directly. What would watchful monitoring, radiation, or a targeted, less invasive treatment look like for someone my age and health profile? That question alone opens a door a lot of people never even realize exists. The fourth is elective joint replacement in someone whose overall health isn't quite where it needs to be yet. I want to say clearly, hip and knee replacements are some of the most successful surgeries ever developed, full stop. For the right candidate, a new hip can be the difference between barely shuffling around the house and playing on the floor with grandkids again. But the word elective matters here more than people realize. It means this is planned, not an emergency, which means you actually have time to prepare your body first, and most people skip that step entirely. In patients over 75 who are also managing several other serious conditions at once, heart disease, diabetes, kidney issues, carrying significant extra weight, elective joint replacement carries a noticeably higher risk of complications during and after surgery. The biggest danger is blood clots forming in the legs that can travel to the lungs and become life-threatening, and in older patients with slower circulation, that risk climbs considerably. Add in the risk of pneumonia from lying still too long, plus the general risk of picking up an infection during a hospital stay, and the picture gets complicated fast. The question isn't whether you should ever get the surgery, it's whether your body is in its best possible shape right now to handle it. Getting blood pressure, blood sugar, and overall cardiovascular health optimized before an elective surgery can lower complication rates substantially. And some hospitals now actually require a structured pre-surgery conditioning program before they'll even schedule high-risk older patients. That's exactly the right instinct. And if your doctor hasn't brought it up, you should. The fifth is emergency abdominal surgery, and this one is different from the other four because you don't get to plan for it, it chooses you. A ruptured appendix, a perforated bowel, sudden internal bleeding, none of these situations wait for a calm sit-down conversation. But it belongs on this list because understanding the risk ahead of time changes how families make decisions in the middle of a crisis. Emergency abdominal surgery in people over 75 carries some of the highest mortality numbers in all of surgery. And it isn't because surgeons in the emergency room are less skilled, it's because a body under sudden, severe trauma is fighting several battles simultaneously, and the inflammatory response that a younger body can usually control within days can spiral in an older body into something far more dangerous, where multiple organs start to struggle in sequence. So what do you actually do with that information? Two things. First, don't brush off ongoing abdominal symptoms, persistent pain, unexplained bloating, or a real change in bowel habits in anyone over 60 deserves a prompt visit to a doctor. Catching a problem early is often the difference between a manageable procedure and a middle-of-the-night emergency. Second, have the conversation with your family now, not in a hospital hallway at midnight. What matters to you if emergency surgery becomes the only option? What does quality of life mean to you? These aren't morbid conversations. They're one of the most caring things you can do for the people who might one day be standing in that hallway making decisions on your behalf. So now that we've gone through all five, let's actually talk about what to do with this, because information without a plan just turns into anxiety, and that's the last thing I want to leave you with. Before any major planned surgery, there are 4 questions worth writing down and bringing with you. The first is simply, what happens if I don't have this surgery right now? A good surgeon will give you a straight answer, and if nothing urgent changes over the next 6 to 12 months, that tells you that you actually have time to think, time to get a second opinion, time to strengthen your body first. The second is whether a less invasive alternative exists, because medicine has changed enormously in the last decade and a half. Robotic procedures, small incision techniques, and catheter-based interventions that simply didn't exist 10 years ago are now available at most major hospitals. The third is what recovery realistically looks like for someone with your specific health profile, not the average patient. You, your heart, your kidneys, your current medications, your living situation. The answer should be specific, not a vague reassurance. And the fourth, the one almost nobody thinks to ask, is what that surgeon's personal complication rate is for this exact procedure in patients your age. Surgeons track this. They know their numbers. A confident, experienced surgeon will tell you without hesitation, and if the question makes the room uncomfortable, that discomfort is information too. There's a second layer to this that almost nobody talks about, which is what you do in the 2 to 4 weeks before you walk through those hospital doors, because that window can shift your odds more than almost anything that happens once you're actually under anesthesia. Surgeons spend years mastering their technique, but almost nobody spends 2 weeks preparing the body that has to survive it. The first piece is often called prehabilitation, and it's exactly what it sounds like, training for an event, because that's genuinely what surgery is for your body. In the weeks leading up, eating more protein matters, since that's the raw material your body uses to rebuild tissue, and a lot of people over 60 are quietly under-eating it without realizing. Walking every single day, even just around the block, matters too, because stronger legs and lungs going in translate directly into getting up and moving faster afterward, and getting up and moving is exactly what prevents the blood clots and pneumonia we talked about earlier. And if you smoke, even quitting 2 weeks before surgery measurably lowers the risk of complications with wound healing and the lungs. The second piece almost nobody thinks about is the conversation with the anesthesiologist specifically, separate from the surgeon. Remember that brain fog I mentioned earlier? There are real practical steps that lower the odds of it happening. Requesting a pre-surgery consultation with anesthesia specifically. bringing a full list of every medication and supplement you take, including the ones that feel harmless like fish oil or an herbal sleep aid, because some of them interact with anesthesia in ways that genuinely surprise people. Asking whether a regional or spinal anesthetic, one that numbs just the area being operated on instead of putting the whole brain under, is an option for your specific procedure, because for a lot of hip and knee surgeries, it is, and it tends to be gentler on an older brain. And a small detail that sounds almost too simple to matter: if you wear hearing aids or glasses, ask to have them with you right up until you go under and immediately when you wake up. Patients who can see and hear clearly the moment they regain consciousness experience far less post-operative confusion, and that's backed by real research on hospital delirium. The third piece is the part everyone forgets about until they're actually living through it, which is setting up recovery at home before the surgery, not scrambling to figure it out after. Arrange your help in advance, know who's driving you home, who's staying with you the first few nights, where you'll actually be sleeping, because fewer stairs in that first week makes a real difference. Clear loose rugs and cords you could trip over. Fill your prescriptions ahead of time so nobody's rushing to a pharmacy at 9 at night while exhausted. The first 72 hours after coming home tend to set the tone for the entire recovery, and a body that isn't also fighting a fall or a missed dose heals faster. And watch for real warning signs in those first days: sudden confusion, a fever, a leg that's swollen, hot, or painful. Any of those, you call your doctor immediately. You don't wait to see if it passes. And the fourth piece, simply get a second opinion. I know it can feel awkward, like you might offend the first surgeon, but let that worry go right now. A good surgeon expects it and actually welcomes it, because they'd want the exact same thing for their own parent. Bring your scans and records so the second doctor is looking at the same information. And if two qualified surgeons look at the same body and the same images and land on two different recommendations, that isn't a problem. That's valuable information. And it's exactly the kind of thing you deserve to know before anyone picks up a scalpel. There's one more layer worth knowing, and it might be the most useful thing in this entire video, because it's about learning to read how a recommendation is delivered, not just what it says. Over time, you start noticing patterns, and here are the ones worth slowing down for. The first is speed. If you're being rushed onto the schedule immediately for something that isn't an emergency, that pressure is almost never about your actual body. It's usually about a calendar. The second is being handed exactly one option with nothing else mentioned, because by the time you're in your 60s or 70s, there's almost always more than one road available: medication, physical therapy, a less invasive version of the same procedure. And if none of that came up, it's not because it doesn't exist, it's because nobody put it on the table. The third, and this is the one people miss most often, is that doing nothing for now is never even discussed as an option, and watching carefully while treating conservatively is a completely legitimate medical choice for a lot of conditions in older adults. The fourth is how your hard questions land. If asking about complication rates or alternatives gets you a brush off instead of a straight answer, that tension is telling you something real. And the fifth is a recovery timeline that gets glossed over with something like, "You'll be back on your feet in no time," because that's not a recovery plan, that's a sales line. The honest version sounds specific: here's week 1, here's when you'll need help, here's the part that's genuinely hard, here's exactly what we're watching for. I want to tell you about someone I'll call Gerald, because his story sums up everything we've just covered better than any statistic could. Gerald was 71, a retired engineer, sharp as anyone I'd ever met, and 3 separate surgeons had all told him the same thing: that he needed open heart surgery for a blocked artery. Gerald wasn't scared of surgery itself. He was scared of losing himself, because 2 years earlier, he'd watched his wife go through a major operation and come out of it confused, exhausted, and never quite the same person she'd been before. He told me once, "She went in as my wife and came out as someone I had to take care of," and that sentence has genuinely stayed with me ever since. When I sat down with Gerald and actually reviewed his full picture, his kidney function, his overall frailty, his baseline cognitive health, I gave him something most consultations don't have time for: 40 real minutes instead of the usual 15. And what I told him was the truth. Surgery was one legitimate option, but so was a combination of aggressive medication management and structured cardiac rehab. And for his exact profile, the long-term outcomes between the two approaches were genuinely comparable. Gerald chose the non-surgical path. That was 4 years ago. Last month, he sent a photo of himself standing at the top of a hiking trail in Colorado, flanked by his two granddaughters, both taller than him now, all three of them grinning like he'd just won something. Here's the single most important thing I want you to walk away with today. A surgical recommendation is not a verdict, it's the opening line of a conversation. You are not a passive passenger in your own medical care, you're an active participant in it. And the moment you sit down in a surgeon's office, you have every right to ask the hard questions, request the alternatives, and take whatever time you genuinely need. The surgeon holds the scalpel, but you hold the choice. And that choice, made with clear information and a clear head, is more powerful than almost anything that happens in an operating room. So let's bring it all together. Open heart surgery in a frail body where less invasive alternatives increasingly exist. Aggressive spinal fusion, where the evidence on long-term pain relief is far shakier than most people are told. Major cancer surgery, where the real goal has to stay focused on more good years of life, not just tumor removal. Elective joint replacement before the body is genuinely ready for it. And emergency abdominal surgery, where early attention to warning signs and honest family conversations are your best protection. None of this means avoid surgery altogether. Surgery saves lives constantly. I've seen it happen more times than I can count, and I'm proud of the work. The message is simpler than that. Be an informed patient, ask the uncomfortable questions, request the alternatives, and get a second opinion, and a third if you need one. Your age is not a weakness, and it never has to be treated like one. Before you go, I want to be completely upfront with you. Everything covered in this video is general medical and educational information based on published research and broad clinical patterns. It is not a diagnosis, and it's not personalized medical advice. Every single person's health situation is genuinely unique. Before making any decision about a surgery or a treatment path, have a full, honest conversation with your own doctor. They know your history, your body, and your specific risks in a way no video ever could. If this helped you think differently about a decision facing you or someone you love, share it with them. That one share might matter more than anything else you do today. Take care of yourselves, stay curious, and keep advocating for your own health. You deserve a doctor who explains everything clearly and treats you like a genuine partner in your own care.